My name is Dr. Jose Luis Ruiz, and I'm the director of the Los Angeles Institute of Clinical Dentistry. And we're talking about resin-modified glass ionomer today. And I was just mentioning that I've been in love with these materials for many, many years. I've done a lot of research on it, and I've used it, very successfully for many years. And I'm very excited to share with you my passion about these materials. And I was mentioning that because we have so many materials in the market, it's very easy to be confused, and sometimes we start forgetting about materials that have been tested and they have been proved to be successful, like resin-modified glass ionomers. It is very important to keep in mind and to remember that with all these amazing materials that we have today, we would expect that dentistry should be easier and faster and better and healthier. I mean, wouldn't you agree? I mean, what is the benefit of having all these advances in technology if we're still having, to struggle with problems? When we really start looking at the current state of restorative dentistry, can we say that we can do our restorations faster than before, like when we were using amalgam? Can we do a composite faster than an amalgam? Can we, can we do things healthier for our patients? Are we doing less root canals? And the answer is right on the screen. And, in fact, the American Association of Endodontists reports the endos are actually increased in the past few years. So is that helping our patients? Are all these advances in technology, are they really making a big difference in benefiting dentists and patients? And the answer is, of course they are, but only if we use them correctly and if we choose the right materials. Because the reality is the composites are amazing materials, and of course I'm in love with composites and I use it all the time. But composites have complications, and we need to keep that in mind. Composites are completely unforgiving to contamination. So perfect isolation is a must. If we don't do that, then we can have the danger of microleakage, secondary caries. Polymerization, shrinkage is a big concern. If we don't manage that correctly, we can end up with open margins or microleakage. Post-op sensitivity is also a big concern, and I speak to at least a couple of thousand dentists every year, and I hear issues with post-op sensitivity all the time. So it's not something that has gone away. So while I love composite, and it's of course is my primary material for direct restorations, it has some complications, and we need to manage those complications. And I tell you, the number one problem is the fact that composite and any resin-based materials are completely unforgiving to contamination. And the most difficult thing to manage is not saliva, it's not moisture in the mouth, it's bleeding gums. It is what we fight the most against, when we have a margin that is subgingival and we need to restore it. The more subgingival, the more difficult it becomes. So subgingival margin and adhesive dentistry are enemies. And so what do we do when we have these subgingival margins? It's a big problem. Now, granted, and I've been speaking about this subject for the past 10 years, that the most subgingival margins are preventable. And there's a number of things, we're not going to talk about this today, but there's a number of things that we can do to prevent subgingival margins. One of those incredibly easy things to do is change the way we prep proximally. We all learn in dental school to do boxes, and when we do boxes, we learn in dental school that we need to create clearance. So we are in this habit of creating clearance by dropping our margins subgingivally. So we might have removed all the caries and our tooth still in contact with the adjacent tooth. And how do we break contact? We keep dropping the margin until we have that separation. And by the time we do that, then we're below the gum, and now we have a bunch of problems. And this is just one of the many things that we do routinely that can put us in trouble with adhesion. And this picture just tells you how severe this problem is. This is a patient who, a 19-year-old patient, by the way, who had a crown done, and you can see that approximately there's no caries. So there was really no reason to put margins subgingivally, but that need to clear clearance, the habit of creating clearance by dropping the box made this crown to be several millimeters below the gum. So this is a big problem. There's a number of different things that we can do to progingival dentistry can really make dentistry easier, faster, and healthier for our patient. There's a number of techniques like enamel preservation, margin elevation, a number of different things that we teach at the Los Angeles Institute of Clinical Dentistry, and we have for the past 10 years, techniques that really make adhesive dentistry way, way easier. So now the thing is that once we have margins, they are below the gum. And sometimes that happens because there's caries. Sometimes that happens because there is an old restoration there. And then we have to deal with that. So how do we do that? Well, there's a number of different ways, but resin-modified glass ionomers and glass ionomers can be the answer to some of these problems. And they are, in fact, the answer to some of these problems. These materials are amazing. And these materials can be used in situations in which if we try to use composite, we may end up, shooting ourselves in the foot. Well, for example, right here, there's a few of the situations in which I would use resin-modified glass ionomer. For example, if I want to do a restoration, let's say a class 5 or a distal of a second molar, where I really have a heck of a time isolating, resin-modified glass ionomer is a great material because it's and we'll talk about why, but it's less sensitive to contamination. Resin-modified glass ionomer have been used as liners. Historically, we have many, many years of using liners, and I'll share with you some research that I've done. For children and deciduous teeth, I mean, that's, when you have how easy is it to isolate and maintain isolation when you have a 5-year-old that is kicking and moving, but then if you use a material that is not as sensitive to contamination, your success goes up incredibly. Geriatric patients, or cementing crowns in situations in which is impossible to maintain perfect isolation. So resin-modified glass ionomers can be the answer to some of these problems. But so why? What are the benefits? Why is it that these materials are unique? Well, one of those issues is the resin-modified glass ionomers have a low module of elasticity. They are more flexible, and that allows them to have less negative effects during polymerization shrinkage. It doesn't mean that these materials don't shrink when they polymerize. The fact that they're more flexible, and I will explain how this works in a few minutes, but that is an amazing benefit. Actually, they can be a bulk film material, and we'll talk about that. They are absolutely less sensitive to contamination. They have, of course, they release fluoride, which we know is quite valuable, especially in our patients that have rampant caries. And these materials are also, historically we know that they have less sensitivity. So they do have some powerful benefits that they're easy to use as well. Of course, it like everything else, it requires some practice. So let's start by talking about liners, resin-modified glass ionomers as liners. So of course, with the advances in adhesion using self-etch bonding systems, which are without a doubt, and of course that would be a different conversation, but without a doubt, self-edge bonding systems today are the ideal bonding system. And when we're using self-edge bonding systems, post-op sensitivity becomes quite rare. So do we still need liners? And the answer is yes, sometimes we still need liners in some situations where we might be very, very deep for direct restorations when we are very close to the pulp, maybe an indirect pulp cap. Resin modified glass ionomers are very, very good materials for that reason. And of course, we've been using them. I mean, I know I use resin modified glass ionomers religiously for many, many years, especially before self-edge bonding systems, but even after, because they work. Because when you line the deep areas with these materials like IonoSeal from Boco, which is very easy to use, Vitribond from 3M, or Fuji lining from GC, these materials are very successful. They really decrease post-op sensitivity. So how do they work? Why is it that they decrease post-op sensitivity? So I did a study with Sumita Mitra, who is the inventor of this family of materials, the resin modified glass ionomers. And these materials, because of the fact that they have low modular elasticity, they can minimize the effect of polymerization shrinkage and eliminate that gap. And we know that micro gap during the polymerization shrinkage, composite shrinks and is sometimes separate from the wall of the cavity and creates these little gaps. These little gaps are believed to be one of the causes of post-op sensitivity. So the fact that the resin-based composite shrink is a very serious problem. Now, resin modified glass ionomer liners can become kind of like a buffer zone, like an elastic material that minimizes the effect of polymerization shrinkage. So how does that work? A few years ago, I did a research study with Sumita Mitra, and basically what we did is we placed 2 millimeters of composite attached to a glass slab, and then on top of that, we put we bond a very, very thin glass slide to this composite, and then cured it. After polymerization shrinkage, and I don't know if you can see this in this slide, but after the polymerization shrinkage, we can literally visually see the slide bending. And then we use a specialized instrument to measure the deflection, and we recorded that. Then to see what a elastic material and an elastic liner can have, we place a 0.5 millimeter increment of resin modified glass ionomer material, and then on top of that we cure that. We cure the liner, and on top of that we put a 2 millimeter increment of composite, cure the composite. And what we noticed is the deflection was about 50% of the deflection that we had without the liner, which shows that flexibility, because if you look at the study from Labella, resin modified glass ionomers are 7 times more elastic than resin, which means they're considerably, they're more forgiving to the effects of polymerization shrinkage. So that's the benefit of a liner. So we still can use it to minimize, because composites will always shrink, and if we want to manage the effects of polymerization shrinkage, then a liner is a great tool for that. And of course, I only use a liner, and I usually use IonoSeal from Boco because it comes right out of the syringe, so I don't have to mix. And it's self-bonding, so basically when I have a very deep cavity where I'm concerned about the polymerization shrinkage of composite, I can put a thin liner of this material, and then do my incremental filling of composite. And I know that this material will help me minimize the effects of polymerization and minimize the chances of having post-op sensitivity. So, or even micro leakage. So this material has still a very powerful benefit in dentistry today. Now, another great benefit still attached to the same, the fact that it's more flexible, is the fact that these materials can be true bulk fillers. So again, when we're working with children or with patients that we truly cannot control the moisture in the mouth, then a material that we can bulk fill is quite valuable. It's quite useful. There's a few in the market. Ionostar molar from Boco is highly filled. Has excellent wear, which is a very important thing, because we know that one of the disadvantages of resin modified glass ionomers and glass ionomers is that they wear very fast. So a material like Ionostar molar that has an excellent wear is quite valuable. Now, this is not really, this would not be recommended for a large adult cavity on the occlusal surface because of the wear. This would be recommended for deciduous teeth, or maybe even a small cavity that doesn't have major occlusal contact. Certainly, they can also be used for class 5s and cases like that. So, the benefits of this material is that it makes dentistry a lot faster and a lot more friendly in those type of situations. Other alternatives are, of course, Keytac Nano from 3M or Fuji 2LC from GC. This photograph right here shows us how well this material is performing even after 2 years in the mouth. This is a couple of fillings. Dr. Lesia Harmer shared this photograph with me of an excellent post-op photograph of a patient after 2 years, and you can see how successful this material can be. Another wonderful use of resin modified glass ionomers would be for class 5s. So, again, as we said before, one of the specific benefits of resin modified glass ionomers is that they are fluoride releasing. So if you have a patient that has clearly a history of rampant caries, if the patient has deep subgingival caries, resin modified glass ionomer could be an excellent option, an excellent choice. Now, granted, resin modified glass ionomers, and especially glass ionomers, are usually not very translucent. They're usually not very pretty. So, we don't want to use it in cases where high aesthetics is desirable. But I can tell you that this material, Ionolux from Boco, is actually quite pretty, and it also has the benefit that it has excellent polishability. So in some situations, even in cases with some slight aesthetic needs, I can still use a resin modified glass ionomer like Ionolux and achieve pretty decent results. If I need maximum aesthetics, then I'm usually going to go for composite. But then again, if it's a situation where I have a hard time isolating, then I wanna start thinking about resin modified glass ionomer. And then you can see some of my own cases with several years post-op. Another wonderful use of resin modified glass ionomers is, of course, the very well-known open sandwich technique. So when we have a situation in which we are deep subgingival and we're having isolation issues, as well as in situations in which we have, again, patients that might have a history of rampant caries, situations in which we are subgingival with no enamel to bond to, then resin-modified glass ionomer open sandwich techniques are excellent. You know, right there on the screen, you can see a few of the research studies that they have demonstrated how successful it is. For example, the Newman research study by a group from Belgium, they did a literature review, and what they found, and what I mean by a literature review is they review a lot of research studies of clinical uses of different materials, including resin-modified glass ionomers and resins, and they found that the most successful, the ones that show least microleakage on class 5s were resin-modified glass ionomers. Abushal and Kugel, Gary Kugel, also show an amazing success with class 2 composites when we use resin-modified glass ionomer liners. And Michael Miller, show excellent results as well with class 2 composites when we use the open sandwich technique. So these are not materials that don't have a lot of excellent history and a lot of research behind them. It seems like, you know, sometimes we forget about those good old materials. Now, granted, there are some studies that they're also contradictory to that. If you love resin, then you always want to use resin. But I think that it is very desirable to have more than one tool in our armament, because once in a while, and this happens to me, once in a while I just cannot control the bleeding on a class 5 on a second molar. And what do? So these are materials that we should always have in at hand. So margin elevation is another different version of the open sandwich technique. So years ago, I mean, you may know that I in my practice I haven't been cutting crowns for probably the past 15 years. I mean, I can probably count with my hands how many times I actually cut a crown in the past 15 years. And the reason why is because I believe in tooth conservation and try to preserve the health of the pulp and staying super gingival. But there are situations like the one that you see on the screen with the caries is below the gum, and of course during my initial years of doing bonded onlays, once in a while, I would try to do a bonded cementation of an onlay with subgingival margins where you have this bleeding gums, and that was totally a nightmare. I would be injecting anesthetic with epinephrine, and I would be, using the laser and every imaginable thing to try to control the bleeding so I can cement my onlay, and I couldn't. And sometimes at the end you give up and you just pray and hope, And of course that's never a good way to go, because it doesn't work. This picture right here, by the way, is of a dentist who came to my office with her onlay in her hand, and she said, this onlay has fallen 3 times. Of course, it wasn't my onlay. And it doesn't mean that it was impossible for me to happen, but this was not my case. And she had that onlay cemented 3 times, and she was asking me, well, what do you think is wrong? I mean, it's in my tooth, it's in my dentin. And the second I saw the situation, I could relate. I said, I bet that every time that your dentist is trying to cement that, it starts bleeding. So because of this, this very difficult situation, some very smart European clinicians like Ditchy and Newman and others have developed a technique called margin elevation. This margin elevation technique the purpose of it is to allow us to repair only the damaged part of the tooth, and then allow us to treat the rest of the tooth ideally. Because the alternative to that, let's say you have a situation like this and you suffer this in the past. A lot of times what we might end up doing is just say, the heck with it, I'm going to cut a crown, and at least I know that I can do a crown pretty predictably. And then, of course, the what pays the price is the poor tooth that we cut 75% of it away. So this technique allows us to basically do like a short class 2, and it can be done successfully with composite, with resin-based composite. We put a matrix band, we wedge it really well, and then we use our, our adhesives, and usually, we want to use a self-etch adhesive, which again, I mentioned before, I believe today is the standard, the best material that we have. And then, of course, a layer of flowable, and then a little restorative composite. Or option B, we can use resin-modified glass ionomer. And again, it's based on the studies that we had talked about before. The resin-modified glass ionomers work really well. Now, we need to use a resin-modified glass ionomer that is a restorative grade. So, Ionolux, Keitac Nano, material that is very, 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 has excellent compressive strength. You do not want to use a weak glass ionomer. So never consider using like a liner and build it up, because that would be a mistake. Liners like Ionoseal or Vitrivon or Fuji lining, those are meant to be thin. So don't keep building with those flowable type of resin modified glass ionomers, because they don't have the compressive strength. And if you put your onlay on top of a weak buildup, then we can compromise our onlays. So good quality, something like Ionolux, which is very, very good material. There's other alternatives, of course, Photac Fill or Keitac Nano or Fuji 2LC. Materials with excellent compressive strength. And then you repair the damage, and this is this is a very extensive repair. Usually most margin elevations are basically just the distal or the mesial box that is deep subgingival. But you can see in this photograph the benefit of elevating the margin, because now this is actually the day of the cementation of the onlay. Now how easy can it be now? There's no bleeding. It's a piece of cake. When you don't have bleeding, controlling moisture is a piece of cake. It doesn't require a lot of complexity, and success rate just skyrockets. So this technique is very, very valuable. Right here, you see another example of the same thing, a very deep subgingival margin, and definitely a complicated case under any circumstance. Even if you think about if this shows up in your office, think about even if you do a crown, you're gonna have a heck of a time packing cord and taking an impression, etc., etc. So this case, I decided to do a margin elevation, and in this case, I use Ionolux from Voco. And now, when we do a margin elevation, there's a couple of things that we need to do, and one of them is you want to do an excellent class 2, short class 2 basically, and you need to take an X-ray. Because if you don't take an X-ray to confirm that you have a beautiful margin there, it would be very disappointed to do an onlay, to go through the whole process, and then find out that you have a little open margin there. That's not a very happy situation. So you do a nice class 2, you take an X-ray, and then you take an impression. And then, or if you have a CAD/CAM machine, then you scan it at that point, and then you fabricate your restoration. So definitely that's a nice option right there. In this particular case, I actually end up extracting the third molar, so you see that there's a tooth missing. And when we're done, we have two margins really. I know this is kind of like against everything that we learn. We always learn that we want our indirect restorations, we want the margin to be on tooth. And this is actually leaving a margin on composite or resin modified glass ionomer. And I know that and I know that's disturbing for some people. Now let's kind of think about this philosophically. I mean, if you were going to cement a crown and your margin was this deep below the gum, even if you were able to take an excellent impression, you did your double core technique, the day of the cementation, you're going to have a heck of a time, controlling the bleeding. What are the chances that you're going to have a perfect margin right there with a direct restoration with just a regular crown? These are going to be difficult. Doesn't matter how you do it. A nice margin elevation with a properly placed matrix band, is going to give you very good results. And if you use resin modified glass ionomer, then the issues of a little contamination is not as stressful. And by the way, this is just one option. It doesn't mean that that's the only thing that we're going to do. I mean, sometimes we might decide to fight the bleeding, which I don't recommend. Sometimes we might decide to do a crown lengthening, and I do that quite a bit. I mean, sometimes the best thing for the case is going to be to either, if you like to do yourself crown lengthenings, or refer them to your periodontist and just have a margin that is more visible, more controllable. And sometimes the choice might be to cut a crown, and that's realistically something that I don't do. But an option might be to cut a crown and use a cement that is more forgiving, which is what's going to take us, is the next thing that we're going to talk about. And of course, sometimes when you have a case that is this bad, that is this deep below the gum, sometimes you might even choose to do an implant. It might be another alternative. So don't crown enamel margin elevation is just one option. It's just one alternative, one thing that we can do if we want to do it. So I'm gonna take a couple of questions right now, and then we'll continue. So somebody asked, in case of an MO with deep decay, can a resin modified glass ionomer place directly without liner base? So so the question is, do we have to use adhesives? I imagine that's the question. Do we have to use adhesives? And the answer is, some resin modified glass ionomers like Ionolox doesn't need an adhesive. It's actually in fact all resin modified glass ionomers are self-adhesive. So you don't have to use an adhesive. And if you were going to use, if your restorative material was resin modified glass ionomer, you certainly don't need to use a liner. All right, so I have one more. I'll take one more question, which is kind of a long one. Let me see. When we talk about disadvantages of composites, how do you like Activa, which recently been in the market? You know what? I have to say, I was just having a conversation with a colleague at lunchtime today. I don't, the reality is there's so many materials and so many companies out there that it's impossible to know and to be able to say how every material from every company works. And to be honest with you, I'm not familiar with that material. I'm very familiar with materials from Voco because I like them. I've been using them for many years. So I'm very familiar with them. I mean, I'm also very familiar with materials from 3M, which are also excellent. So, but when it comes to the one that you mentioned here, I apologize. I can't give you an excellent answer. So now let's talk about crown cementations for a few minutes. So how many times when you remove an old crown, you find out that the margins are deep below the gum? And the answer is probably most of the times. It's a very common problem, So when I replace old crowns, although I don't cut crowns, but I replace a number of old crowns, and most of the times I find that I have to deal with all of this situation, the bleeding, the deep subgingival margins all around. And if that's the case, then what cement should we use? Well, the answer is depends on what crown you're going to use. So this slide right here kind of gives us a little bit of an idea. So zirconia is very, very, and depends on what research study you read. Zirconia is very close to 1,000 megapascals, maybe exceeds 1,000 megapascals in some studies. It is way strong. Even gold bends at 400 megapascals. So zirconia is double as strong as gold. Lithium disilicate, on the other hand, is about half that strength. And then if you start looking into materials like Empress or feldspathic porcelains, you're usually going to be below 100 megapascals. So if you have a situation like this, and you're going to be struggling to control the bleeding, wouldn't it be easier to use a cement that is more forgiving to contamination? Of course. So then we would consider materials like Meron Plus, which is a wonderful cement, or Fujisem or Relax Luting. But then let me go back here. Then what crown do we want to use? Now, based on this slide, if you use lithium disilicate and you cement it with a resin modified glass ionomer, then now we are losing half of the strength, because the literature shows the lithium disilicate, when it's cemented and not bonded, it has about half of its strength. So that might be a little bit dangerous, and this is especially in the molar area. So I can tell you that I placed, I cemented a number of resin modified lithium disilicates or Emax, and I've had a few that broke when I cemented them. So if you want to cement a lithium disilicate, you want it to be, if you really, really want to cement a lithium disilicate crown, then you want it to be thick. Studies by Ma and others show that when it's 2 millimeters is going to be stronger than 1. So then you would need to either, if you have a tooth that is already aggressively prepped, as we see right here, then maybe a lithium disilicate that you cement with Meron might be an option. But then, on the other hand, if you have a crown, a margin that is bleeding, then you can always use a zirconia crown. And the beauty of zirconia is that even if it's very thin, it's very, very strong, is double as strong. So then a zirconia crown might be the ideal crown to use in this situation. And the ideal cement to cement zirconia crowns are resin modified glass ionomers, because the first benefit is forgiving to contamination. So while we don't want the tooth to be with lots of blood, but if a tiny bit happens to occur during the cementation, it's not the end of the world. So that's my deciding factor. So if I have supergingival margins, then Emax is usually my favorite crown to replace an existing crown. If I have subgingival margins, then zirconia is going to be my favorite crown. Usually layered zirconia, and I will use Meron AC Plus to cement it. Really, Empress for crowns is undesirable. I mean, look at how much weaker it is. It's really asking for trouble. So those are some of the amazing benefits and the amazing uses of resin modified glass ionomers and 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 glass ionomers in general. So I see that there is another question right here. Would you consider a resin-modified glass ionomer as a sealant in difficult patients? And that's a very, very interesting question. I think that I wouldn't, and that's something that I have not read any research. I think that that I would much rather use a resin, and when I do a sealant, I will sandblast the tooth, I will etch it, because I want a sealant that is really going to stay there for a long time. So no, I don't think I would use a resin-modified glass ionomer. Another question: what's cement for metal crowns? And the answer is, one more time, it depends on where the margins are. So if your margin is below the gum, I would say every time you want to use a resin-modified glass ionomer. So because controlling that bleeding is unpredictable, and if you use resin cement, then you're playing Russian roulette. If a tiny bit of blood happens to come out during the cementation, you might have leakage from day one. So that would be my answer. There's another question right here. Do you prepare the zirconia crown and inside surface prior to using resin-modified glass ionomer cements? And that's a great question. Absolutely yes. Absolutely yes. You probably have noticed that when you get your zirconia crown, from the laboratory, is like smooth. It's like super smooth. So it would be very, very problematic if you don't prepare it. So the ideal way to prepare a zirconia crown is sandblast it with aluminum oxide, maybe like 50 micron aluminum oxide, and then use a special silane. And currently, my favorite silane for that type of situation is a material from Carrara called ceramic primer. There's others in the market, but CR, Gordon Christensen's group, which I'm very involved with, have found the ceramic primer gives us the best results. So yeah, that would be the way that I prepare the crown. So there's other materials like C-Prime from Visco and others. So another question is, what would you prefer to use as a core buildup? And I feel that the resin is probably best because definitely resin is stronger. So for a core buildup, a stronger material is best. Then of course you have to make sure that you have excellent isolation. Otherwise, the consequences would be leakage from day one. So definitely we want to. But you for core buildup, you for sure want to have resin. Another question. Have you followed your cases in which you use resin-modified glass ionomer to see how long they last? And I'm sure you're talking about margin elevation. Have you had problems with secondary caries leakage in which using resin-modified glass ionomer? And the answer is, I have followed them for a few years. I really haven't had any that has had secondary caries. And my personal experience only reflects what the literature, I'm going to go back to one of the slides that I showed earlier, reflects what the literature shows. The studies from Newman and let me go a little bit further back, right here. Newman, Miller, and Gary Kugel, and Abushala. I mean, all of these studies show how successful, and how good of a marginal seal we can achieve with the resin-modified glass ionomer. So my experience with it is very, very good. one disadvantage of glass ionomer or resin modified glass ionomer is that if you have a patient who has a dry mouth, and of course that happens to older patients, then glass ionomer can start drying up over time. And that can be a big disadvantage of resin modified glass ionomers, because it needs the oral moisture, and of course the saliva. I mean it also needs the saliva to reactivate the fluoride release. So so that might be a disadvantage for patients that have dry mouth. Another question right here is, what cement do we use for a post? And again, I would use today, ideally, if we're going to do a post cementation, we need to have really, really good isolation, and resin cement would be my ideal option. There's a number of great materials. Futura Bond and Bifix cement from Voco is an excellent material. My brain, the name just escaped. Panavia B5 from Carrara is an excellent material. Panavia, of course, has long history of success. Do you need to use varnish for open sandwich technique? Definitely no varnish. Definitely no varnish. I would never use a varnish in between my tooth and the resin modified glass ionomer. I actually have read some studies, and I wish I had it. I wish I was able to share this study with you. But I actually have read studies where you can use a primer and to get a slight better adhesion between your resin modified glass ionomer or glass ionomer and your tooth. And some materials like Fuji, they have primers. In some situations, I personally like to use a primer and my formula. And I'm not sure if you what I do. I mean, it doesn't. I actually been meaning to do a study on this, and I do like to prime my tooth before I use my resin modified glass ionomers, and I use the primer from Clearfield SC. I use the primer, not the Bond, because I want a primer. The nice thing of a primer is that it still is pretty hydrophilic, which means it allows the fluoride release to continue to occur. If you bond, then the fluoride, the connection between the glass ionomer and the tooth disappears. So then you don't have the benefit of the fluoride. So, but if you use just the primer itself, it being that it's very, very hydrophilic, it still allows that communication between the tooth and the resin modified glass ionomer and the fluoride release. So that's what I do, and it works really well. And I've been doing it like that for at least 10 years. So when I use my resin modified glass ionomers, I use some type of a primer usually. Another question. Percentage could, I'm trying to I have a hard time reading this one. What percentage be used? So can we use resin modified glass ionomers as for permanent restorations on adults? I mean, I imagine that's more or less what the question means. And the answer is in some situations, if you have a patient, if the surface that we're restoring is not a high wear surface, is not in the occlusal section of the tooth, maybe you can use resin modified glass ionomer, because one of the disadvantages is the wear. Now, if you use Ionostar Molar from Voco, then that material has excellent wear. So that's something that we can consider. But definitely glass ionomers have too much wear compared to resins. One more question. Are you worried about low bond strength to dentin using resin modified glass ionomers versus composite? And that's a very interesting question. You're a smart person. It turns out that the adhesion, the mechanism of adhesion between between resin-modified glass ionomers and tooth is slightly bit different than the mechanism that you have with resins. And while you're correct, the adhesion itself is a little bit lower, and you can increase it by using a primer. But while it's lower, it also the flexibility of the glass ionomer increases that retention. So it's this research studies that you see in front of you, really show that these materials are very successful, even in class 5 situations, which is, as we all know, the most the restorations that debond the most. And even in those, what you would expect, a lower adhesion of the resin-modified glass ionomer would mean an increase in failure, but that's not what we see, and that's not what the studies have shown. So, that, I hope that answers your question. We're going to take one more question. I think our time is running out, so one more question. When you do scaling around resin-modified glass ionomers, open sandwich technique of filling, can this create an open margin? And if it's just glass ionomers are a little bit weaker. Resin-modified glass ionomers, on the other hand, have better compressive strength. They're stronger. Nevertheless, it's always smart and it's always desirable to be careful when we're doing when we're scaling around margins of any restoration. So I would always indicate to my hygienist to be a little careful in those situations. You don't want to create an open margin by careless scaling of a root surface. So well, it's really been an absolute pleasure to share this information with you. These materials have been materials that I've been in love with for many years. I've used them. They're part of my armamentarium in my practice. When it comes to crowns, my absolute go-to cement is Maron Plus, or any resin-modified glass ionomer. We at the LA Institute, definitely, I mean, I'm in love with adhesion. My passion is adhesive dentistry. In fact, right now we're in the process of publishing a book that Dr. Ray Bertolotti and myself wrote called Supragingival Dentistry, a healthier option to restorative dentistry. And this book is being published by Wiley Blackwell, and it will be out probably in a few months. So on that book we talk about adhesion to amazing details, very advanced adhesion. So trust me, I love resin, I love adhesion, I love bonded composite, and that would be probably my most used material. But resin-modified glass ionomer and glass ionomers are materials that we cannot forget. We have to keep them in our armamentariums because they are very valuable in some situations. And it's been an absolute pleasure to share this information with you. This is my website. If you have any questions beyond the seminar, you're absolutely welcome to send them through our website, and it's been a huge pleasure. I wish you a wonderful rest of your evening, and until the next one.